Thank you. I'm Simon from Peninsula Health. I'm privileged to be one of the senior clinicians with the Keeping Families Safe program, which, as we've heard, is one of the ASIS programs that was initially piloted following the recommendations from the Royal Commission. So we were asked to briefly provide an overview of our program, which would focus on our catchment area, our cohort, the criteria of our program, and modifications that we've made to the Step Up program, which really includes, for us, the development of therapeutic family work. We've also tried to identify some key learnings from our program, and also we'll briefly look at how we currently evaluate our program. So the program is currently located in Frankston and covers the catchment area of the city of Frankston, Mornington Peninsula, and more recently, the city of Kingston. The program can, however, see families outside of these areas as long as they're able to travel to Frankston. The, catchment area is quite mixed from a social economic perspective, and this is really highlighted, I think, from the Jesuit Social Services report, both in 2007 and in 2015, which really identified that particularly Frankston North is one of the most disadvantaged areas in Victoria. Alongside that, Rosebud West and Hastings have also been identified as having quite high proportions of disadvantage. And this is kind of mixed in with other very kind of quite affluent areas, particularly alongside the Bayside Peninsula area. So just looking at some of the, context from the families that we would see. And I think this is fairly consistent with a lot of the presentations that have kind of come before us. But really just to clarify that the majority of clients within the program are aged between 14 and 16 years. We have, however, more recently seen, an increase in referrals for younger people aged between 12 and 13. It's hard to tell how sort of statistically relevant that may or may not be at this stage, but the average cohort is between 14 and 16. Again, I think as we've heard a lot from other presenters, we're seeing a real mix of complexity and kind of challenges within the young people and the families that we see, and this would include issues of certainly young people identified or diagnosed as being on the autistic spectrum disorder, having various challenges with intellectual disabilities, ADHD and ADD. Struggling to see the slides here. So the majority of clients that we would see would be male clients. That would form about 80% of the young people. And I think, again, just to sort of clarify that the majority of families are very much often sort of sole parents, and the primary carer usually being the mother. So just to kind of briefly talk about the criteria for the program, it's a free and voluntary service being part of Peninsula Health's wider community services. The criteria really is, there's two kind of main criteria around age. So the young person is very much our client, but you'll hear a bit later on that we focus very much on a kind of family perspective in the context of the young person in the family home. So the criteria is age, so the young person has to be above 12 years of age or above when they start working with, or when we start working with them. And the other criteria is that there is no ongoing adult intimate partner violence at the time of referral. The team is a sort of multidisciplinary team. We're quite a small team consisting of 5 EFT, and we come from a mixture of backgrounds, often social work, family therapy, as well as clinicians from more sort of specific adolescent mental health backgrounds. A big part of the work is very much focused on safety planning and risk reduction. And we use very much an integrated family violence response to look at risk. And it's often involved a lot of other sort of integrated services within the family violence sector. Again, we try to, I guess, see families really where they're at and look at responding to the family and the young person's needs within the context of their kind of individual needs, and we try to develop very much a family-focused response to that, which can often also incorporate, I guess, a kind of case management perspective to try and coordinate clear service response within sort of service integrated frameworks. We can offer up to 20 sessions. This is often extended depending on, again, the individual needs of each family. And I think what we're finding is that when families engage with us, or when we're able to engage with them, often the intensity of the work can go well beyond the initial sessions. Referrals are received primarily from the Orange Door, as well as from Peninsula Health's own kind of intake service. And a big part of referrals comes from schools, child protection, youth justice, would be sort of typical agencies referring to us. So I'll now hand over to my colleague Chris, who will talk a bit more about the adaptations that we've made from the Step Up programme.
Hi, I've been with the program now for about 5 years. So just briefly, the original group work program was developed in America, the Step Up program. It was a mandatory program, ran for 20 sessions, and it used quite a heavy literacy-based session plans. We've adapted the material from Step Up and formed our own session plans for the evening groups that we used to run for both young people and parents. The material that we included did include adolescent developmental stages. The sessions were more interactive, flexible and responsive to the needs of the group. We used visual, oral, some reading and writing exercises from the material. Usually they were for take-home activities, and a lot of experiential-based activities, including, well, for example, games, but they were always related to the particular theme of the session. We found that that was not just effective for young people, but also effective for the adults or the parents that were there as well. We found the sessions provided opportunities for families to feel that, less alone feeling, that they weren't the only ones. And it encouraged a lot more active listening to each other, either within that family group or to other families, to get valuable information and insight from just the group session. The majority of the young people, which surprised us initially, committed to the 10 sessions, so it was quite a big commitment for a young person who initially probably wouldn't want to actually be there. They found it very helpful and we had good feedback from them. And I think, like has been mentioned before, is that the young people, what we asked them, how come you're still coming? Because we were feeding them pizza and stuff, was that they said because we felt heard, and that was clearly very important for them. And I think it was really good learning for us, just in our program generally, not as well as a good learning for the parents too. But currently we have less group-ready families due to increased complexity, with the referral, as has been mentioned, regarding pre-existing disorders, disabilities, etc. We have offered daytime programs to parents, generally mums, because they often have younger children as well. Although often childcare is, or the lack of available childcare is quite restrictive for some of them as well. So we haven't had as many group programs as we have had in the past. Now, the development of outreach and therapeutic family work. Outreach to engage the young person at home, if isolated or refusing to attend a centre. We generally, often a parent will present and they'll say, no, the young person's not going to come along. So we will organise a home visit to try and engage with that young person. So we always take two workers for safety. Sometimes that takes a couple of home visits, but ultimately what we find is the young person does want to have a say. And once they get involved in that conversation, generally we can work quite effectively with them. And then we can meet with them either at home, school, cafes, other centres, as well as our own centre. We use a family therapy approach, which we find most effective in bringing about change and insight into family members when they're fully engaged. We do meet separately with the young people and parents. Sometimes it's 50-50, maybe in one session, or the parent is happy to drop the young person into us and we meet with them and then they'll go home with the parents. So we had the full session, but we normally do a bit of a catch-up either beginning or ending of that particular session. The young person, we certainly don't use that term perpetrator. We think of them, like has been mentioned before, it's just not a perpetrator, but in the context of the family dynamics and the behavioural issues that they present with. So we generally observe family interaction so that can inform us with appropriate interventions to use throughout the time that we spend together. We can use, when we have the services available, we can use two workers to work with particular families that we might find have extra challenges. We find that works quite effectively. Otherwise, the majority of times it's usually just one worker for the family. Once families are engaged, there is a noticeable de-escalation in the violence and aggressive behaviour from the young person. And we think that is due to, one, there's a change in the system when workers become involved, and that usually family members often feel supported so that they are able to be importantly heard, both the parent and the young person as well. And we certainly focus a lot on effective communication. Key learnings. I don't know, Simon, if you want to jump in on this as well. So the identified gaps in the integrated service response. Specialist adolescent family violence service appears to be overlooked and underutilised. Therefore, high-risk situations can escalate. So, for example, we did have a family that we were working with, a mum for 4 boys, and due to family violence, it was still occurring with her and a partner who was in and out of the household. The family were moved to a refuge. We then, where we were sort of organising care team meetings, we were then not really in the picture once the statutory authorities were involved. So therefore there was no support really for this mum when we were quite well engaged with the whole family at that time.
One of our most significant key learnings is often the need to really look at coordinating services from a more of a classic sort of case management model, when we're often finding that, particularly with the onset of NDIS, so families often experience a lot of services, and so we're very mindful of not over-duplicating work, or really trying to be clear on role and how we kind of evaluate the effectiveness of when multiple services are involved. probably conclude now so you can hear from the other people. Just very briefly on, I guess, our own program evaluations. And I think we've sort of come to recognise that they are not sort of currently as sophisticated as perhaps we would like. We mostly rely on self-reporting from the family themselves, and we undertake some kind of fairly detailed assessments and questionnaires at the beginning and at the sort of conclusion of our intervention, and it's done very much in partnership with parents and the kind of young people themselves. But I think kind of moving forward, we're recognising that we would like to develop a kind of a bit clearer, kind of comprehensive evaluation process that would look certainly post-closure of the sort of success of the program, or how effective the intervention may have been after we've concluded. Because at the moment, I think that's an area that's really kind of missing in